I have a quick question. We see the emergence of chemsex, and obviously it's very different community from what has been done, what you have shown here. Are those services and so forth suited for this new emerging community, or how can we adapt to that?
Well, I don't think that, let's say, traditional harm reduction services are suited to address that. So again, this is an excellent example that only makes a difference if you work with peers. So you have to work together with MSM organizations and activists, and starting from there and to build from there prevention and information and addressing the issue. So, but I mean, this chemsex thing is indeed very much related to drug use, so it makes sense that harm reduction is looking more into that particular group and work together with the activists in that field.
Yeah, because you mentioned the demographic shift.
Yeah.
In drug use, or the people who use harm reduction programs. So yeah, that's where the younger demographic will be.
Yeah, I mean, this is quite specifically in the Netherlands. You see that in the tendency also in other European countries, but it is the most effects you see in the Netherlands in terms of this demographic effect. In other countries, like in Germany, you still see an increase of young drug users as well.
We might start the panel. Oh, is it a question of clarification or for the panel discussion generally?
It'll be a question for Mr.
Sorry?
So do we need to now change the guidelines that we have for harm reduction in relation to needle exchange and increase the bare minimum equipment needed if we are to aim in decreasing Hep C incidence? Because I know HIV is a bit more fragile, so we had quite a minimum, and some countries started with the bare minimum required. So do we need to modify the guidelines now?
I mean, that's a very important question, and actually I should have addressed that also in my presentation, that for HCV prevention you need a much higher coverage of harm reduction services, needle exchange programs than for HIV. As we know, the infection is the virus is 10 times more dangerous than the HIV, so that means also for harm reduction services a very better skilled hygienic policy within their services, also in drug consumption rooms, and this is very much still underestimated in many of those harm reduction services. So I think WHO's recommendation is something about to reach coverage is something like 200 syringes per person in a certain region. This is a very much average estimated a number. I don't know. I would not even know how they estimated it. It says almost nothing. So the main point is that you need high coverage, and that is. And what we see, of course, is that in rural areas, in most countries, there is no coverage. If you speak about drug consumption rooms, you have one in Canada, so that says nothing. So all these kind of services really need excellent coverage to make a difference on HCV.
That brings me to my question that I'm going to put to the panel and to the room. I think the thing that's always struck me about harm reduction is the massive variation across the globe. We've had examples that will happen, you see in the Netherlands, we'll have the circumstances in Russia. Despite some scientific evidence, some of it strong, some of it weak, about the effectiveness of harm reduction. So my question to the panel, and also to the audience, is, we're not going to get a perfect world here, but over the next couple of years, as we're striving for elimination of these, bloodborne viruses, what's the kind of information that you think would be important for us to try and gather to help persuade governments, some of them very resistant, others less resistant, but even in a country like Australia where we're pretty pragmatic, we don't have a needle and syringe program in our prison situation. So what do you think we need to be doing to move things along? And similarly what do we need to be doing in terms of evidence for just getting people to just overall reduce their use of needles and syringes in health services? I'm just really interested in how we try and move it forward so that in 2 or 3 years, maybe we've improved things a bit. Not perfect, but a bit. I'll leave that to any of you. What are people out here?
I think this goes back to the point that you made earlier about the need for a more robust evidence base in order to inform guidelines. I've recently been looking for guidelines for what harm reduction services should actually provide. And other than kind of woolly, generic, we should have opiate replacement treatment and we should have needles, syringes and other equipment, there's very little I'm aware of in terms of international guidance on exactly what the intervention should be and how they should be delivered. So that would be my big plea for the next few years. And if anyone's aware of anything, come and grab me in a break and point me in the right direction.
I would not totally agree with that, because I think we know very well what should be done, and there is enough evidence out there what works and what not in regard of harm reduction. The problem is to transfer that to the floor to convince policymakers. Even if there's the evidence, even if you know that it is cost effective, in many countries it is not adapted, there's not enough coverage and so on. So that is a missing link in that. And my point is to bring that higher on the agenda, that we need more synergy and more cooperation between the medical sector, between the academic and research scientific sector and the practitioners. That is what I miss in many, many cases. So I'm very happy that it is included now here in this program, but I was seeing the program, I saw, hey, there's nothing about harm reduction, how it's possible. So it's still, I think, the researchers, academic world is very much acknowledging harm reduction, but there's still, I feel, a big link, a big missing link to the practice.
I'm going to agree in part with both of you, but I'm going to point out when I was involved in the WHO guidelines again for HIV, looking at key populations, and we were asked to look at the data on dead space for syringes and the evidence for it. It was non-pathetic. When we were asked to look at the actual impact of peers on harm reduction programs and the evidence that a peer, as opposed to a well-trained worker, was effective, cost-effective, and what their true impact was, the data was negligible. So there's things we know, OST, we're getting better. It's only just recently we've got that opiate substitution therapy is likely to reduce hepatitis C incidence in a way that I could actually argue with a government official hand on heart, similarly with needle and syringe programs. So I think we often think things work, and they probably do work, but I take your point about if I was to say to my minister, hand on heart, spend an extra amount of this money paying for peers to do this as opposed to not, it's really, really hard for me to find that evidence. I mean, I don't know whether anybody else... I'm just interested... So to me, I take the point, but I'm interested in other people's experience of this and ways that... what we can do to make it easier for you and others.
Yeah, so, I mean, I would say that for hepatitis C, the evidence of harm reduction that it has an important effect is only really sort of just evolving. I think people agree that it has an effect on HIV and evidence has accumulated over that. But I think people were thinking, Hep C is so much more infectious, I don't think these interventions are effective. But I think the evidence now is sort of accumulating that they are effective, but it's just whether it's enough for hepatitis C, which I would agree that because of it is more infectious than HIV. It's a lot more needs to be done to bring hepatitis C down to sort of elimination levels, which has occurred for HIV in certain countries for the injecting drug user populations. But I also think for needle and syringe provision, it is really hard to know how different components add together to contribute for hepatitis C risk. I totally agree that there's a lot of things which are good, and I wouldn't argue about that, but for actually showing, this has this effect on hepatitis C, maybe we'd never be able to do that because there's so many different components. But just for a guideline on how many syringes somebody needs to make them safe, I mean, the WHO targets, if I was at one of those meetings about that 60% coverage, and it's not evidence-based in any way. And I think it is hard to know actually how many to give someone. I mean, it seems to make sense you should give as many as the injections that they have. But then when I talk to people, they say they need more than that because they'll use one syringe and they didn't manage to find a vein, so then they use another syringe. So it is hard to know how many syringes they need to make them safe.
Unscientific response, it's stroke of luck, how you deal with the minister and the secretary health. You do advocacy, you put data in front of them, sometimes they listen, and provide excellent lip service. But then it fades away. So advocacy, persistence, some hardworking, on-ground stakeholder who's very passionate about it. This recipe is, I don't know, it's a combination of these things. So data and evidence, they will understand maybe prevalence, okay, things like that. Beyond that, it's hard for them to understand.
But that's also a thing that bothers me, because coming from Russia, I know that the countries that are, and the governments that are susceptible to scientific information and data and advocacy based on data, they're already implementing harm reduction interventions. And you can study like small, technical details of peer involvement, or, I mean, science can develop, but it would not help to promote harm reduction in countries like ours, where science doesn't mean anything, and even cost effectiveness doesn't mean much in the light of ideological resistance. So, in my view, also, I think it's very important. I don't know how epidemiologists can do it, or infectious disease modelers can do it, but it's very important to study the wider political context, I guess, and, for example, the effect of decriminalization that you mentioned on the health of the population and access to health services and human rights and the epidemics.
I'm conscious that it's lunchtime, so I think if people have other specific questions or the like, I just want to thank the panel. I think this is a really complex and difficult issue, and again, a bit like with testing and all of those things, there's work that we need to keep on doing and trying to work out what's the most effective work to get the biggest bang for our buck in all of these areas. So thank you all. And it's lunchtime. Is there something I need to say about lunch? No, go and enjoy lunch.